Yeah, so welcome everyone. We're going to be talking about some of the basic TNE views. And I did do a much longer recording on the website of the Neocardio Lab with in like 3 parts that are like in total like 4 hours. But today we're going to be doing a first part, like 1 hour, really go over what we can as much as possible. But just so you know, there's guidelines by the American Society of Echo of how to do measurements for both TNEs as well as guidelines for how to perform like pediatric transthoracic echoes. And that is available with the QR codes there, so you can go and scan, and they're also on the TNE curriculum website. So we're going to start by the classic views. What I always say is that, when you're doing a TNE, you're there to get as much information as possible in the shortest amount of time, especially if the baby's critical. So you have to adapt your scanning sequence to get all this information. If you know already that the heart is structurally normal and it's been seen by cardiology, then really you should focus on your question and then get the information. But let's say that you're actually the first one scanning and then your images will eventually be reviewed, or that you're later on going to get like a structural scan by cardiology, then you probably also want to include all these views to make sure you're not missing something. There are also sometimes lesions that will appear later in the course of patients. So for example, when a PDA is large and open, you may not see that there's underlying pulmonary valve disease and pulmonary stenosis because you have a left to right duct. And because of that, the left to right shunt will create flow into the pulmonary artery, will transmit pressure, and there's crowding at the area of the pulmonary valve, and you just don't see that there's like pulmonary valvular stenosis because of that. So sometimes it can be difficult to uncover that in some of the patients. If the PD is wide open, you may miss also coarctation in some of these patients, although typically critical coarctation will have bidirectional PDAs. It's very rare that they'll have a strict left to right, but it could still happen if the PVR are very, very low and the SVR are relatively higher. So just be aware that when the PDA closes, it's something you want to recheck, is making sure your arch is okay. So you will need a suprasternal view. And pulmonary veins, even if you look at them structurally on the first echo, it's something that you always want to recheck in all of our patients, especially the preterms, because there's this entity of acquired pulmonary venous disease that they can have. And a lot of the scans that you may do in your population might be screening of BPD pulmonary hypertension, and it's something you want to check for. So we'll go over some of the classic views, but often I get asked, what's the sequence of where you start? When I trained, we often start by the parasternal view. There's many centers that will start right away with the subcostal. Very easy to start with a subcostal in a patient that is limp, poorly reactive. So that's an amazing view because you get all the information in one view almost. But the problem is the subcostal is in babies that are kind of more active, more awake. Once you start to touch the belly, they can guard and it could become a bit more of a challenge to image them. So optimize your setting for imaging. It's very important. So depending on like what's the baby you're going to see. So if you're seeing a 500 gram, you always want to have in mind, like, what am I going to scan? What's the information I need? And there might be views that if you don't get on the first shot, you might skip and go to the next to get the information just because they lose their temperature so quickly. Versus if you have like a 4 kilo term baby, very kind of stable, and you're asked to do an evaluation for like infant of diabetic mother hypertrophy, and the kid is hemodynamically stable, then probably you have more time to really assess fully like the heart. That's just like too extreme of like situations. And so most scenarios, I'll start with the parasternal long axis just because I was trained to start with there and right away I get information about function. But many centers will also start with the apical view because it's typically an easier view to obtain at the beginning. So for like scanners, it's an easier place to go to get like some of the information on right and left atrium, right and left ventricle relationships and things like that. So these are like some of the views you get with the parasternal long axis view. So typically we'll start with what we call the mitral aortic continuity view with the LV. So typically you want to have a bit of the RV on top. You want to see that you have your left atrium, your left ventricle, and your aorta. Then you will tilt posteriorly because the inflow is posterior. So the RV is like a banana from posterior to the front in typical conformation. So the front is the pulmonary valve and the RV outflow tract and the MPA versus the back is your RV inlet. And this is like kind of the anterior view. So you're more anteriorly positioned. And at this point, you see more your RV outflow tract, your pulmonary valve, and your main pulmonary artery.
Can you explain 1 second what these diagrams are next to the views, the sort of 2 arrows and the 10, 11?
These things?
No, well, yeah, I guess the ones I was looking at.
Yeah, so yeah, these are ones by Pacini who actually tried to code how she would get the images for people. I find it's, quite challenging to get it until you actually scan, but this will provide you like the anterior, posterior, inferior, superior axis of where you're at relative to the rest of the body. And it provides you some information of what's like what's superior, inferior, and anterior, posterior is basically your spine versus your sternum. So that's what kind of these arrows are telling you. So here you're in an axis where you're mostly anterior superior because you're in this area. So you're anterior superior, and the back here is more the inferior posterior limbs. So that's what this telling you. So here you see this is Chiran doing the parasternal long axis. Typically, in most babies, you'll be around the sternum in the exact area where you would like listen for the A or P kind of focus. Although we know that in babies, that's not true. It's not the A and the P. So it's typically around the parasternal zone, around the third intercostal space. It's actually a bit of a lie. It's actually a bit higher in most babies. And then you need to like orient yourself almost perpendicular to the chest, although sometimes you do have to tilt a bit with kind of the tail of the probe a bit closer to the chin of the baby. So kind of angulate a bit more posteriorly to cut more posteriorly. So what do we see in a parasternal long axis view? We see a bit of the RV on top. We can appreciate the interventricular septum. We see the posterior wall of the left ventricle, and then we'll see the mitral valve. This mitral valve has two leaflets. And what's very typical of a mitral valve is that you never have attachment of the mitral valve to the septum. Your mitral valve will always go to the posterior wall or to the lateral wall of the left ventricle. And the septum of the left ventricle is typically very smooth compared to the septum on the RV side, which you can see there's a bit of crowding here. It's a bit more hypertrabeculated. So the RV is a hypertrabeculated mass versus the LV has very thin trabeculation and the septal surface is very smooth. So already right on with this view, you could already start seeing, oh, this is odd if you had like something called a double discordance that they sometimes call like CCTGA. Which is like a congenitally corrected TGA, where your RV is going to be connected to the left atrium and the aorta. And typically you'll see that the attachment of this valve will actually go to the septum, and it's because it's a tricuspid valve, because tricuspid valve has multiple attachments and some of them going to the septum. Also, your mitral valve will open in diastole and will close in systole, while the aortic valve is opening in systole and closing in diastole. And so you have here two cusps of the aortic valve, and you can see it open nicely. And sometimes you can even appreciate the left coronary artery kind of coming out from here on top. And so that's the left coronary cusp, and under it is the non-coronary cusp that we cut here. And this is the view where you would measure your kind of LVOT. So in this view, you get a sense of function. You can see if there's fluid accumulation in the back. You can see your descending aorta here. You see your LA, so it gives a sense of left atrial preload. So preload of the left ventricle comes from the LA, and LA gets fed by the pulmonary veins. So LA preload will drop if you have less pulmonary blood flow. If you have obviously a lot of venous dilatation, and so you get pooling in your lower limbs, or if you're very low in preload because you had third spacing, or you bled out, or you have low intravascular volume. Because the RV gets less fed, and because it gets less fed, your eventually pulmonary blood flow drops, and eventually your LA gets less preload as well. So then you can go posteriorly. We're typically going to see the posterior leaflet of the tricuspid valve and the anterior leaflet of the tricuspid valve. And then there's a septal leaflet of the tricuspid valve that we'll typically see in short axis, whether it is in parasternal short or in subcostal view. You do get to see a bit of what we call the right ventricular inlet, which is the zone of the right ventricle that will receive blood flow. The RV is a tripartite organ. It has an inlet, a body, and an outlet. And what's nice about the RV is that its outlet is very muscular. So it's a cone of muscle that sits just under the pulmonary valve. This is very different than the left ventricle, which doesn't have this cone of muscle. If you can see, the mitral valve and the aortic valve are actually abutting to each other. So they have what we call fibrous continuity. So that's very particular to the LV, is that there is mitral aortic fibrous continuity. And if you see our patient we delivered this afternoon and you do the TGA scan, you're going to see that there's mitral pulmonary continuity. They don't have, the pulmonary valve doesn't have a conus anymore because it comes out of the left ventricle and it sits in the position of where the usual aorta would be. And typically, these patients have what we call a subaortic conus because the aorta is coming out of the right ventricle in TGA. Does that make sense? Conus is like a cone of muscle. So it's just that's what we call conus. So it's like sitting under. Sometimes you can have conus anomalies. So conotruncal anomalies like TOF, DORV, truncus arteriosus. So these are truncal anomalies that comes with DGeorge syndrome. This is the right atrium, so sometimes you may see your line float inside this view. So that's one of the view to see if you have a UVL or a PICC line that's very far. And sometimes you can appreciate a bit of the inferior vena cava just here. And you can sometimes see a bit of the eustachian valve that we see mostly from the position of the subcostal view, which is important to recognize because sometimes people will mix it up for either a rim of an ASD, which is not a rim of an ASD, it's a valve of the IVC, the eustachian valve. And the other thing that sometimes people will mix it with is like a PICC line or a UVL. RV outflow tract, it looks like a bird that's like flying, right? This is the pulmonary valve. Before the pulmonary valve is the RVOT, and after the pulmonary valve is the main pulmonary artery. In this view, what we're interested is to make sure that the pulmonary valve is opening and closing nicely. So it's good to have a view in 2D to make sure that the valve is opening and closing. And when you put color, that you actually see flow originating before the valve. So this, we're going to just quickly go over again. Parasternal long axis view. You see the valve here, which is the mitral valve. The mitral valve, when it's in systole, I don't know if you notice, when the aortic valve is open, this whole corridor is wide open. There's nothing that comes in front of it. When you start having infant with hypertrophic cardiomyopathy or septal hypertrophy, it will pull a bit of the base toward, during the contraction, it pulls like everything towards the aorta. And sometimes this mitral valve will have a motion that comes in front of the aortic valve. We call this systolic anterior motion of the mitral valve, and this can obstruct the outflow tract. And these patients can be very sick, and so part of their treatment is obviously to relax them. So esmolol, give more fluid, making sure that they're not depleted. And part of their treatment might actually be to rise the SVR so that when the aortic valve is open, it stents this LVOT and it removes the apparatus of the mitral valve from the way. And there's actually more and more in adult cardiomyopathy where they look at these measurements to predict those patients that will end up with like severe outcomes, but that's not for us yet. The M mode, just so you know, has been abandoned by the cardiologists of the adult world. So if you speak to your wife, Ben, yeah, so they don't do M modes anymore. Actually, it's been discouraged and it's been abandoned by their guidelines. We still use it in our population of patients because a lot of the literature we've built through the years is based on these measurements. So because of that, it's been kept, but I can tell you that it's going to be eventually probably abandoned. Why? Because it's very angle dependent. It's very like, where's your view? Because what do you do with an M mode? M for motion. And basically what you do is that you take a line of interrogation and you obtain the information along this line through time. So on top of it, you see the QRS, this is time, this is the depth, you see the heart rate, which is based on your ECG. And then from here, you're able to see, first of all, the interior wall of your right ventricle, which is a portion only that is near the RVOT. So it doesn't tell you everything about the RV. You can see a portion of your RV cavity. And then you can see the septum. With a portion here, you see these kind of little fizzle. This is mostly like sometimes attachment of the tricuspid valve that we can obtain also at the M mode level. So really what you want is those clear delineated margins of your septum to measure your septum in diastole. So I know this is diastole because it's just at the QRS or before the QRS. And so at QRS, you're going to get activation of your ventricle and eventually you get contraction. And so you see that this septum will get nearer to the posterior wall of the LV and you get thickening of your left ventricle. So you use these different measurements, first of all, to measure your LV and diastolic diameter, which provides you an information of whether or not your LV is dilated. So some markers of PDA significance will be based on LV and diastolic diameter. So you can put it, get a Z-score. If your Z-score is more than 2, you know you have dilatation of your LV. Number one. Number two, you're going to look at the shortening fraction, which is a ratio between your LV diastolic diameter and your peak systolic diameter. And so this ratio will inform you on function. So if you're above 30%, usually is quite reassuring. And then sometimes you can look at what we call the E separation point. What's the E separation point is that here you see there's 2 leaflet of the mitral valve. You get the anterior leaflet and the posterior leaflet. So anterior leaflet here, posterior leaflet here. And then you get, during diastole, this early phase of filling. So the mitral valve will open in like kind of early phase and then active contraction of the atrium, so atrial contraction. And so you get these two flickers that we call the E and the A. And the separation between the peak of this E and the septum, the closest it is to the septum, the more your LV is vigorous. So in the emergency room, actually, that's like one of their markers they use for function. They actually put the probe, they do an MO, they measure this E separation point. If it's good, ciao bye. If it's not good, they continue to look for like cardiac POCUS assessment. So it's a very cardiac POCUS, but it's not really a TNE measurement. But if you read literature and you see this E separation point, that's what the E separation point is. If I have...
And so you would compare it to like a
There is normative value, but I never use them. Yeah, so I'll show my screen so you can see. It's great because if you're not sure about something, you go on the website and you write E separation. Do I have it? E point separation point, E point septal separation. And then you go here. I've put it because I've had some people from the POCUS world that asked me. Actually, I've put it under normal parasternal short axis. And it's, yeah, so there are normative values that were described. Yeah, so you see here, very short E separation point. Like, so this is the E separation point, okay? So you have normative value for babies, and typically they say for term baby, you should be less than 2 millimeter for what it's worth, versus this patient and the one we scanned this afternoon, if you remember well, there was a lot of E, like a big E separation point. So already when you did the MO, I was already starting to suspect, ooh, there's something a bit weird. Why? Because the LV has become dilated, and so it's more filled at the end of diastole. You also can do it in short axis if you're better, yeah, if you're better angled. So you can see that this is like what the TNE guidelines tell you. So in the TNE guidelines, they recommend both in the long axis, or if you're better aligned, to obtain it in the short axis. And you can see that there's a bit of the anterior mitral leaflet and posterior mitral leaflet, and that you should be at the tip of the mitral valve. And you can get your end diastolic diameter and your end systolic diameter to get a shortening fraction, basically. You can also do what the ASC is recommending, which is actually to measure it in the 2D and not measuring in the M mode. Just so you know why people had like this obsession about M mode, especially in pediatrics. M mode allows you to obtain a very high frame rate. Frame rate is basically like how many images you get in a second. So if you go see a movie and there's like 2000 frame rate versus 2 frame rate, it's going to be looking much more choppy at the 2 frame rate compared to 2000 frame rate. So you get much more temporal information. So you're really able to track very, very accurately the motion of these walls compared to when you're obtaining it in 2D, where by definition, you're going to lose in your temporal resolution because you're not going to get that much frame rate. Does that make sense? Okay, so then we do typically a zoom on the aortic valve and the LVOT in order to make sure that we can measure this left ventricular outflow tract. This is the example. So we're going to go at the hinge point of the aortic valve at the peak of when it is open. So that's just an example I've put here for measurement. It will be important for you to measure it in order to get LVO. If you do a cardiology rotation, they're often going to go and then measure also what we call the aortic root, the sinotubular junction, and they'll get what we call the ascending aortic arch measurements diameter above the RPA. So remember I told you when you were scanning, try to see your RPA so you can see your ascending aorta, because if you need to qualify, oh, there's dilatation or hypoplastic ascending arch, that would be the measurements where you get it. Yeah, it's very on top at the middle of your RPA. Very rare we need to get this information. It's something that more cardiologists will get from their perspective of making sure there's no congenital heart defect, but it's something you don't want to miss. If suddenly there's like a massive aorta, you at least want to be able to get the measurement, call your cardiologist and see like, I saw this patient, I need a cross read or I need your like structural heart echo. That's just to show you that depending on where you get your aortic valve, you could cross-cut very quickly your LVO. So that's why LVO sometimes can be difficult to measure, or there's like less reliability in the sense that depending on where you cut your aortic valve or your bouton aortique, you're going to have issues at getting a diameter. And knowing that this diameter is put to the square it can create some issues. So what's important is basically keeping consistency among people doing this measurement. So typically it's like the way you do it, you should always do the same if you're going to be taking care of the patient based on only this marker, which you should never. Basically, you should use a combination of marker to decide what to do with your patient. You're going to see many babies who have asphyxia, and they get, obviously, first of all, decreased metabolic rate. So first of all, they need less cardiac output to match the metabolic demand. But on top of it, some of them will have profoundly decreased LV or RV function based on high pulmonary hypertension or coronary ischemia or things like that. You'll see that their VTI and their LVO is going to drop significantly. And sometimes we see that and we act on this to like improve the inotropy, improve the heart rate. So that's why often in asphyxiated baby that are bradycardic with poor cardiac function, if we see the lactate is rising and we're concerned and we on echo have bad LV function, what medication would we use? Yeah. Like dobutamine would be like often like a first choice because it improves heart rate. And we know that babies have inherently their inherent contractility, which we call inotropy, is usually something very difficult to increase, especially in patients that have already had subendocardial ischemia and LV issues. And because they have such bad SVR, because of the cooling, they get a lot of like vasoconstriction. Their LV is struggling even more. So one of the first agent we often will start, knowing that they're bradycardic, is trying to improve their output by at least getting some of the chronotropic advantage of dobutamine, and then which gives slightly a little kick for the inotropy. And there's the theoretical possibility that it helps a bit stabilize the SVR or decrease the SVR, at least not increase the SVR. Epi is a really good drug when you have severe LV dysfunction, but it increases. Yeah, so you're right. So at low dose, so as soon as you reach your like 0.05, 0.1, you start having much more of this like vasoconstrictive effect. And so it can worsen sometimes the LV, this component of the LV dysfunction. It can start facing a lot of afterload, but sometimes we have no choice to get a bit of low dose epi. Okay, LA on aorta ratio, very debated as well. LA on aorta ratio was designed by Norman Silverman, described back in the 1970s or 80s. Delicious person. He has great YouTube videos you should go see. But basically what he described is that it's a marker of left atrial dilatation or a marker of aortic hypoplasia. So if you have a ratio that is increasing, always think that it might not just be the LA. Be careful because the LA on aorta ratio can be high in any newborn who had a PDA for a certain period of time. So if you're seeing a 29-weeker and now the PDA is closed, the LA on aorta ratio may still be above 1.5. And that's because the LA has been receiving more QPQS for a bit, and it's just going to take time for this LA.
Like we often see it like in those old babies.
It can take like 2 months.
Okay, good. It's just like in terms of like days.
It's very common. It's very common. And it has not been really designed to be used in patients like, because often it's been designed to be used in tiny preemies or in babies with like very large VSDs. That's been like the cohort that they've studied. It's also been criticized because if you have a huge ASD, the LA is going to decompress very easily, and your LA might not dilate. So your LA on aorta ratio may not be that high. But we saw a baby this week on the unit that had like a massive left atrium, and you didn't even need like an LA on aorta ratio to tell you like this kid has a massive left atrium. So how do we measure it? There's a few techniques. This is the one that's been described by the TNE guidelines. So you see closure of the valve, and the closure of the valve takes place up to here. Then you get opening of the valve, and then the valve is open up to here. So here you'll see it better because you actually see the tracing of the two leaflets of the valve. So you have the left leaflet of the aortic valve and the non-coronary leaflet of the aortic valve. This is the point of closure, and it's closed. So you see the raphe of the valve up to here, and this is where it opens. So if you look at the guidelines, they would actually measure it here, and we measure it at the point of closure instead of here. And the reason we do that locally here in our guidelines is that this is how it's been described by Norman Silverman like 30 years ago. But there's been studies since then many times that looked at like the comparison, and it's basically the same pretty much. So it gives the same results. What's important is to get the LA at the largest measurement, when is the LA the largest measurement? In ventricular systole or in ventricular diastole? Ventricular systole. Mitral valve is closed. LE is still getting filled by the pulmonary veins. So the LE is like getting bigger and bigger and bigger. And when the mitral valve opens, you get like a gush of flow into your ventricles. We like sweeps. Why? Because it gives you a relationship of anatomy. So at least in one of the views, I always get an anterior to posterior sweep. Because I'm starting with the parasternal, it's often the view that I get a sweep very quickly, like right away, just to get a sense of the relationship of the vessels, the anatomy, the relationship of the RV, the LV. Here you see the RV flow tract, the aorta. You see that the aorta and the pulmonary valve, the aorta and the MP are actually crossing to each other. So they're at almost 90 degrees. So we already know that, these are not parallel vessels. In this view, as I mentioned, you can get your RVOT, your valve, you can measure your RVOT. This is the two example of how they might be in a different angle. So you have here your aorta and here your RVOT. And this is how I would measure the RVOT at the hinge point of the valve. So we can even see kind of how this valve is here and here, and this is the hinge point here. And I get a measurement that's like 7.7 millimeter. So just for you, Ben, you can see that this valve, this is a non-doming valve because the leaflets are really abutted along the wall of the MPA. And we can see it nicely on this clip also, where you see this valve is like completely abutted to the wall. So there's no like doming where the valve has difficulty opening fully. You see with color that there's no acceleration of flow. Here, this is your Nyquist. This here is a left pulmonary artery. This is your left ventricle. This is a parasternal long axis. So you know this is the left and the right is going that way. And you can see that there's a bit of acceleration, and this kid probably has a bit of like peripheral pulmonary stenosis. Because just by the angle, just because the in babies, like it's not a Y, it's more of a T, and because of that, it creates this turbulence. So typically what we will do, we would get a Doppler at around the valve or just maybe like an inframillimeter below the valve. And this will allow you to get a tracing of the what we call velocity time integral, which informs you on the stroke distance. So in this particular patient, you have a heart rate of 138, and you see that your velocity time integral is 0.0072 meters. And that's informing you on stroke distance, basically. It's an estimate of the stroke distance because we're doing a pulse wave Doppler at exactly that area. What is that? So that's a very tiny restrictive PDA. Left to right looks like a bit of a flame. And you can see that there's a lot of aliasing even, like it's becoming like turquoise/yellow because the machine is not even able to tell you the directionality at the point of constriction because there's so much like turbulence and it's kind of flowing like a circle. So that's another example of when we would get, don't be full on the still image because the still image, there's motion of this pulmonary valve. So we'll often align our pulse wave Doppler at around the area of the valve. And sometimes when we actually get the image, it looks like it's just above the valve, but it's often like intentionally placed at the level of the valve. And then here you can see that you get a smooth acceleration and a smooth deceleration. So this Doppler to me looks very benign. You get good velocity, close to 1 meter per second, and you get about half of your period in systole and half in diastole. And you remember how I told you, like, a lot of the algorithms are based on 1/3, 2/3, thinking that we spend 1/3 in systole, 2/3 in diastole. Babies actually spend about half and half. So if you look, and the more you get cardiac dysfunction, the more time you spend in systole because your ventricle needs more time to empty. So your time in diastole will actually shorten. So in hypoplastic left heart syndrome, one of the key markers of function, because it's an RV and not an LV, and so it's difficult to apply some of these markers of function that we have, is to look at the TR and to look at the systolic to diastolic time ratio. If your systolic to diastolic time ratio is more than 50%, you start getting concerned that this RV is struggling.
I have a question
Yeah.
about the RP and the LP, because you said like, oh, you see acceleration,
Yeah.
or just by the angle. How would you know it's by the angle and it's not like an actual stenosis? Like,
Great question. We actually need to look in 2D. Okay. You need to look at, so typically if you have like severe stenosis, first of all, your gradient will be much more than 2 meters per second, except if you have complete atresia or blockage, then you just don't have any flow. So you don't have any gradient, right? So that's the first thing. Second thing, typically you'll see the caliber of the artery to be very small on your 2D views and your mustache view. So that's one concern. Third thing, typically the lung that's affected on the X-ray will look completely black because you had just no pulmonary blood flow. So that's another indirect sign that you might not see by TNE. We often see that with CDH. So your left CDH, you'll see they'll actually get these hypoplastic, tiny left pulmonary artery. There's not much you can do about that, but you'll see that the flow is much more restricted. And actually, one of the markers of fetal prognosis was described by Jean-Luc Bigras, and it was a ratio of the LPA to RPA diameter in fetal life.
So if it's super small, then it's probably.
It's a worsened
like
prognosis.
worse.
Yeah.
Yeah.
So that's just an example of me being at the RVOT area. So you see like the valve is just kind of here. I'm just before at the valve level and I'm getting like a contour and I can get my VTI, which here is in centimeter because it's Tomtec and not single. And then I can get the exact time that I spend and for this cardiac cycle. So here, the time I spend is 446 milliseconds. So if you take 60,000 and you divide it by 446, it gives you 134 because, basically it takes you 440 seconds for one beat. How many beats do you get per minute, basically? So it's to calculate. Yeah.
On this, one time Dr. Spinell was doing an echo and she was doing exactly this. And she said, she was looking for a nice envelope.
Yeah.
Is there any other way to get this envelope, get a nice envelope other than just by trying to change around where you're taking in the valve?
So you need to be the best aligned. So first of all, your alignment, we say that the angle of inclination should be less than 30 degrees. And actually many textbooks will tell you even to be less than 20 degrees. So what does that mean is that this is the line of interrogation and your vessel is like this. So if your vessel is like almost perpendicular, you're never going to get a good signal. Why? Because you're looking at the traffic like in front of you instead of being inside the traffic. Okay. So first you need to find a view where you're better aligned. That's number one. So sometimes you can get a very nice RVOT view from the apical area if you do a RV3 chamber view, or even from the subcostal when we do that anterior sweep, or we could do that TED view and be best aligned. And sometimes the best alignment, it's not just about, sometimes it's about motion of the probe to really be en face of the valve. So that sometimes you need to move your probe to actually be in front because then and it's the same thing with TR to get best TR is to actually you always need to have the least angle of inclination. Okay, short axis. What time is it? 3:13, my God. Okay, so short axis is a 90-degree often of the parasternal long. We're going to go all over these views you will see. So typically, your first view is what we call the aortic view or the aortic button view. What you want to see is a tri-leaflet aortic valve, and not when it's closed, actually when it's open. Because when it's closed, most of the bicuspid aortic valve will look tri-leaflet because they have three cusps, but they often have a fusion of either the right coronary cusp and the non-coronary cusp, or the left coronary cusp and the non-coronary cusp. That's like kind of the most common ones. Why do we call this the right coronary cusp? It's often because the right coronary comes out of here, left coronary cusp because this left coronary comes out of here. Majority of patients, right? You have coronary patients with coronary abnormalities. And then you have the non-coronary cusp because usually you don't have a coronary here. You can appreciate how I see my aortic valve from in front versus my pulmonary valve, I see it from the sideline. So you can appreciate that these vessels are not parallel. Actually, the aorta is coming out of the screen. On the side, you have what we call the tricuspid valve. You can even see a bit of the attachment here of the septal leaflet of the tricuspid valve to the interventricular septum, which is just under this aortic valve, because remember the aortic valve has fibrous continuum of the mitral valve, which sits just under it. You have the right atrium, the left atrium. Here you have the interatrial septum. This is not a good view to interrogate the interatrial septum. Why? Because this is almost in line with your probe. So you're always going to see some flow passage here, even if there's no flow passage. It's just like mirroring artifacts. In adults, they use this view sometimes to see if there's PFO and stuff like this. We never use that because it's not a good view for that. We use just subcostal. So then you can go a bit higher and see your aorta transected. And then if you remember well, we could see the pulmonary valve and your right pulmonary artery, left pulmonary artery. And this is where you would see if the caliber of your LPA and your RPA don't look similar. If you have like a really kinked LPA, very tiny caliber at its ostium into the MPA, then that's where you would see that there's hypoplasia. It would be very unlikely that suddenly the ostium looks good and then distally it's like super tiny. Very unusual. Yeah. But in babies, we have the advantage that typically we'll see the nice mustache view. You have the main pulmonary artery and pulmonary hypertension. That's a good view to make sure your FPA is not like fully dilated. It's also a good view to be aligned to get CW through your RVOT. Why would we get CW through the RVOT? if you want to make sure there's no subvalvular, valvular, or supravalvular pulmonary valve stenosis. If you want to make sure that there's no pulmonary insufficiency and you want to get some of this information of pulmonary velocity during diastole. And then if you have a gradient through your pulmonary artery because there's like an obstruction by a clot or something like that, which is very rare in babies to have like pulmonary embolus. Although it has happened here that we had a patient in a massive IVC, massive IVC clot, and we were worried that it would embolize, so it could still happen. So again, this is the tricuspid valve. We often see it also in the short axis. You see the anterior leaflet, and then you see the septal leaflet of it. And then you can go a bit lower. So just below the aortic valve, we have this continuum of the mitral valve. The mitral valve has typically 2 leaflets, and it looks like a fish mouth. So the opening of the mitral valve should be nicely seen in this view. If you have any concern of acceleration, this is a good view to make sure your mitral valve is not stenotic, which can happen after like endocarditis in some of the patients. So here you have the anterior leaflet and the posterior leaflet of the mitral valve. And then there's 2 papillary muscle. So here it's the back. This is the front. This is the lateral. This is the sternum. So median. So we call this one the posterior medial papillary muscle, and we call this one on this side the anterolateral papillary muscle. Just so you know, because it's a question on your quiz that everyone got wrong. The other thing you see here, this big muscle here is called what? In the middle of the RV cavity, there's like a muscle, bande modératrice, the moderator band. So there's a nice morphological section in the Neurocardio Lab website, which talks in depth about what's an RV and what's an LV. Moderator band defines often like the right ventricle. LV will not have a moderator band. Sometimes you'll see LV tendon, which is actually fibrous tissue, which is like a little line that looks like a PICC line. It's not something that will get thicker because it's not muscle. It's just like a tendon. It's literally like fibrous tissue. Versus the moderator band, you see it actually on contraction. I don't know if you appreciate it, becomes thicker. You see it here. Whoop, whoop, whoop. There you go. So that's muscle, right? So that tells you this is the RV. So if you were in cardiology, and sometimes if we're doing the first echo and they're going to be a cross read, you want to make sure your coronaries are well aligned. So here we see the right coronary artery ostium. You should always have it in 2D because sometimes some of the pericardial folds, because I didn't tell you, but there's area around the pulmonary artery conus that has pericardium. I told you the pulmonary artery is coming out in a conus, like a cone. Around this cone, there's pericardium. And sometimes the fold of this pericardium can look like a vessel. And some people will say, oh, this is the right coronary artery, and just will take a still frame and say, this is my right coronary. And then they're wrong. Actually, there's no right coronary. And the patient has either right coronary coming out of the LV, of the left coronary, or has like a anomalous coronary coming from the pulmonary artery. So you always want to see during motion that you have a nice path from your coronary leaflet, from your right coronary leaflet inside your right coronary, which on dit souvent en français, c'est un mariage arrangé. It's a wedding that arranged marriage. The right coronary will go to the right and will feed the right ventricle. The left coronary will come out of the left and will feed the left ventricle, and they have no choice about that. Except there are some that like are a bit rebel, and then they decide otherwise, and these are very rare. And then the other thing is that if you notice here, I've decreased a lot my Nyquist. Why? Because the coronary flow happens in diastole, except in diseases like hypoplastic left heart syndrome, in which the flow is being fed in systole retrograde by the PDA. And then here you can see that you have here the right coronary artery that's coming out of le bouton coronarien, and then feeding in diastole your left coronary. So here you actually see the flow. That's what you want to see. You wouldn't see any flow, and you wouldn't see the actual ostium of this coronary coming out of like le bourgeon. Yeah. So I think here, for example, I have an example of that. So here we see, this is the coronary, the right coronary. You see it? Sorry, I realized maybe on the screen. Do you see that? That line? This is pericardial fold, right? Because it doesn't connect to the bourgeon aortic. And then here you see nicely the left coronary that's actually coming out and dividing into the circumflex. Okay, and sometimes you can even get color, although you're not as well aligned to get color because we're kind of in front, en face of the right coronary artery. So then we'll typically get, so you can get your LA on aorta ratio as well in this view. So similarly to what we had previously. And then you can measure your pulmonary valve open. So you can get your pulmonary RVOT. You could measure it here as your pulmonary valve open. So that's an example of measurements of the RVOT. Do you see it? There's like a little line here. And then you can get your VTI for your output as well here. So yeah, we spoke. So if it's parabolic, so you get a smooth acceleration and a smooth deceleration, it's typically that there's no high afterload to the patient. And once you start having increasing afterload or that your RVOT is facing a higher obstacle, that could be a very large PDA, for example, that's shunting left to right and flooding the pulmonary artery. This RV, so this the shape of this Doppler may be more stiff to the point that you can even get something called a mid-systolic notch. Sometimes they call it a flying W sign, but it's not true. It's not a flying W sign. Flying W sign is something on M mode. It's really a mid-systolic notch, and it looks like this. So how does it look? Is that you get your QRS, you get your beginning of ejection, you get the peak of your ejection, and then you get deceleration of your ejection time, and then you enter diastolic phase where your pulmonary valve is closed. And so you can measure this ejection time, and as you get increasing afterload, this smooth pattern will become more and more triangular with a steep acceleration and a more progressive deceleration to the point that you can get what we call a mid-systolic notch. And the reason they get a mid-systolic notch is because they get a rebound. Because what happens is that the afterload is so high that the RV is ejecting. The MPA has compliance, so it will build up some energy. So some of the blood flow will actually balloon the MPA, and this MPA will recoil and give a second wave of acceleration. So you get this kind of deceleration and reacceleration when the MPA is actually recoiling. And then you can also get something like a pre-systolic forward flow, but we're not going to get there. But if you're interested, yeah, go read on pre-systolic forward flow. It's on the NeoCardio Lab website. Yeah, so you just go pre-systolic forward flow. Very rare, mostly for the population of TOF repair. I think I've put it into the, actually, I think I've put it here. Parasternal. Oh, I think it's here. Parasternal short axis. And then if you go here and you go down and you go into the Dopplers. No, I didn't put it here. Pulmonary hypertension. I put it in pulmonary hypertension. I think. Il fait chaud dans cette salle. I'm very warm. Phenotypes of acute PH. LV and diastolic extrusion. Anyways, there you go. Pulmonary and diastolic forward flow. It's this. You can go read on it. Question.
You know, there's the waveform. You're saying that that second sort of peak is the MPA just
recoiling.
And it's interesting that it's going, it looks like it's going in the same direction as the initial sort of ejection. So, but the flow is going in the opposite, right? And
so you get flow forward. So your RV, like let's say your RV is like, let's say your RV is like this, and you have your valve open.
Yeah.
And this is the tricuspid valve. So this tricuspid valve is closed because the blood flow is going this way.
Yeah.
Okay. First, the blood flow is trying to go this way, but here it's very blocked.
Yeah, but that's your initial sort
so
of.
your initial may go and balloon here.
Right. But on the way.
So when this recoils, it goes back like this.
Oh, I see. It still pushes in the right direction.
It still pushes forward. It still pushes forward because the RV is still contracting. So it's not going to go backward because your pulmonary valve is still open. But you're right that sometimes when you have very severe pulmonary hypertension, we get something called swirling. So what is swirling? Is that some patient with such severe pulmonary hypertension, you'll actually see during systole flow going like this. And then when the valve closes, sometimes you even see flow going backward. We call this swirling. It's like a toilet bowl. you see kind of this effect. That's like in very severe advanced pulmonary hypertension. Rare that you'll see that in the newborn. So so if I go back, these are some examples. So this is a patient that has a very smooth, like parabolic envelope. This is an example of a patient who has a very steep. This was a patient with CDH who had like some high PVR phenotype. Again, I think you can appreciate how this is a very nice parabolic, very smooth acceleration, deceleration. These lines, this is the motion of the valve. When you see these lines, this is closure of the valve. It's basically your valve is closed and then you have no more flow. Okay. And diastolic or pre-systolic forward flow is often you'll see that you'll get a little blip here, actually. And that's often because you have high right atrial pressure. But you'll go read on it on the website. It's a bit complicated. This is another example where you actually see a bit of the mid-systolic notch. I don't know if you see it here. We can appreciate it a bit here as well. It's like, it looks like a W. That's why some people call it a W. I think we see it a bit here too, where you get a bit of deceleration and reacceleration. And that's an example when you have a duct. When you have a duct, you can get a lot of contamination of flow from the duct coming from the PDA towards the pulmonary valve. And so you may start getting like this contamination of flow. So sometimes it's best to obtain these Dopplers in the actual apical view or subcostal view because you get less of that contamination of the signal. Oh, the beautiful Doppler. Do you guys know what this Doppler is?
MPI.
Pulmonary insufficiency jet. So what does the pulmonary insufficiency jet inform you? It informs you on the diastolic portion of the cardiac cycle. That's also on the quiz. So typically, the curve of an aortic or pulmonary insufficiency is a curve in diastole where you get an early phase of diastole, which typically you'll get a higher acceleration because your RV and your LV in general will be sucking up like kind of all the blood. It's empty. So that's the lowest pressure during diastole in your LV or your RV. As your LV and your RV are getting filled, the pressure in the cavity during diastole will rise because anytime you take a box and you fill up fluid in it, your pressure along the wall will become a bit higher, right? You get a bit more wall tension. And so that's why you see this particular pattern of initial higher pressure. And as the diastole goes further, you start losing a bit of that pattern. Why? Because towards the end of diastole, the difference of pressure between your pulmonary artery and your RV is the minimal. So you get less difference of pressure. So this is a gradient. A gradient means that you have a difference between two chambers. So this informs you about the gradient between the PA and the RV during diastole when the pulmonary artery is closed, when the pulmonary valve is closed. So you can estimate or guesstimate what we call the diastolic pulmonary pressure using this index. We would typically say that the diastolic pulmonary arterial pressure is equivalent to the end diastolic velocity to the square. So that's your Bernoulli equation times 4 plus the right atrial pressure. Why? So plus around 5. Okay, so you know that if you look at a curve, you get like systole, and then you get like diastole, and then you get systole. So even in diastole, the pressure in your pulmonary artery will kind of drop a bit, right? It's never like a plateau. Okay, so it's the same. So we're taking this pressure basically. That's what we're interested in when we're looking at the end diastolic, which is this number 2. Okay, and so this would, let's say you have like 3 meters per second there. So that's 3 fois 3, 9, 4 fois 9, 36, 36, a gradient. If you're assuming that your RV pressure is the same as your RE pressure because the tricuspid valve is open and 2 structures that are connected will equalize pressure, and that it's 5, you do 36 plus 5, it gives you about 41. So you can assume that your diastolic pulmonary arterial pressure is around 41 millimeters of mercury. So then you can look at what's happening in your system. So your diastolic BP in your systemic vasculature. Let's say, I don't know if it's like 80. So you know that in diastole, you're about half systemic. But the definition of pulmonary hypertension after 3 months of age at sea level is having more or equal to 20 of mean pulmonary arterial pressure. So if my diastole is already 41, for sure my mean is more than 20, right? Because the mean is higher than the diastole. Yeah. Did that make sense or was that too quick?
Yeah, we did that yesterday.
Perfect. Mean pulmonary arterial pressure. Some studies have looked at like correlates between cath lab and echo, and people have seen that the mean pulmonary arterial pressure can be quite well correlated to the peak velocity of the pulmonary insufficiency jet. So here we call it the early diastolic PI velocity to the square plus that RA pressure. So for example, in this patient, your mean pulmonary arterial pressure would be guesstimated at around 38 because this is where you get from your velocity. Okay, so this is 4 times the velocity, gives you 32.59 plus 5 of RA pressure gives you 38 millimeters of mercury. So that would be an estimate of your mean pulmonary arterial pressure. And your diastolic pulmonary arterial pressure would be the end diastolic velocity before you get in systole.
That's what we did. Okay.
That's why we do the two measurements. Often in peds and often in NICUs, the pulmonary insufficiency jet is like you don't get enough of a jet, and so you can only get like the either a peak or sometimes you're able to get the end. It's very rare you get both because you often don't get a full envelope. When you get a full envelope, you have to be very worried that actually you don't get too much PI, and that's a problem with this metric is that if the pulmonary insufficiency is significant, so moderate to severe, you can't really use that because there's rapid equalization during the diastole, okay? And patients who have a lot of aortic valve insufficiency or pulmonary valve insufficiency, they're going to get a lot of retrograde flow from their pulmonary artery or their aorta, and so there's less effective forward flow, so that can impact output of the ventricle because you're kind of going retrograde. The other thing that it's going to do is they're going to equalize very quickly the pressure so you can misinterpret the gradient. Why? Because your RV and diastolic pressure will be very high. It's not just going to be 5, it's going to be like 20. Does that make sense? So then you're estimating, oh, it's only like 20 or 30, but actually you have 20 of end diastolic pressure in your RV, and really you're at 50 of mean pulmonary arterial pressure. And then the last thing is that you lose your isovolumetric relaxation time because you're actually filling your RV or your LV during relaxation. So you cannot count on some of these markers looking at the RVRT. So if you have a lot of PI or a lot of AI, you cannot do like markers like the MPI or markers looking at the RVRT. So if you have a lot of aortic insufficiency, which is sometimes a problem we have with PDAs because the aortic valve starts to dilate, you can't really look at this IVRT with the same lens than another patient at day 1, day 2, or day 3 of life.
Because it's never really isovolumetric.
Because you're not going to spend, because you're just not going to have any relaxation time that's isovolumetric because you're filling your LV during diastole, right? But in any case, it will give you a very short IVRT, and with PDAs you get very short IVRT, so it will just confirm, it will fit the phenotype, I would say. So that's another example for you guys to practice. This is another pulmonary insufficiency jet. Same concept as TR, RVPA dilation, the PV annulus will dilate. You get early insufficiency jet speed, which gives you estimate of mean pulmonary arterial pressure. And these are the equations. And I've put the reference here. This is an amazing article by the group of Denver. You should go read it. It's by Dr. Joan and Dr. Dunbar RV. They're really excellent at explaining these, so you should look at it. And this is also what has been provided by the TNE group, although they use this equation, which I'm not necessarily a big fan of, like the 1/3, 2/3, for all the reasons I explained to you, that we don't spend 1/3 and 2/3 in these cardiac cycle. But this is true that the diastolic pulmonary arterial pressure is this value. So the end diastolic pulmonary insufficiency jet. So then we go down, we look at our base. We can see a bit of the tricuspid valve, which does not have the same shape as the mitral valve because it has trileaflets. We can also look at our M mode in this view. It's also discouraged by the ASC, American Society of Echo. And then we want to look at the mid-papillary level, we have the 2 papillary muscle, to look at our RV that's very crescentic and the LV under it to make sure that it's very round at the peak of systole. So you want to make sure that at the peak of systole, it looks like a nice circle. And this is a nice crescent. And why peak of systole? Because in systole, your RVOT and LVOT are open, and the RV pressure will equalize with your MPA unless you have a blockage, and your LV will equalize with your aorta unless you have a blockage. And so if your LV pressure is much higher than your RV pressure, it should look like this, and you would hope so. So if you see flattening, then you have to start thinking about, why do I have flattening? Do I have flattening because I have pulmonary hypertension? Do I have flattening because I have LV hypotension? Do I have flattening because I have both, like IRV hypertension and LV hypotension? So that's where, whenever you're going to be looking at post-tricuspid shunt, so VSDs, PDAs, at septal flattening, like it's always a relationship between the system and what's happening in your pulmonary circuit, or what's happening after like the outflow tract, at the level of outflow tract. So of course, a patient who comes in with severe pulmonary valve stenosis will have a big dilated RV and will have a bowing septum because the RV is extremely pressure loaded, compared to if you have an aortic stenosis, you may have a very nice, very big, actually dilated LV that will look like squishing the RV because there's such a big pressure load on the left ventricle.
Let's go flattening on the right here.
Here, so let me show you. So this is in diastole, looks nicely circular. And then in systole,
It falls on itself.
you see, it looks like a D.
Yeah.
And look at the RV, how big it looks compared to the left ventricle. Okay, so this is when we do a full sweep. So I like to do sweeps also because it helps me understand like the segmental contraction of the left ventricle and look at the entire LV. It helps me also look at like my relationship between my RV and LV. We see the moderator band kind of here. We see the papillary muscle, we see the anatomical relationship. And these are different examples of like severity of septal flattening. So nicely round here. Septal flattening is present here with some RV dilatation. Here you have septal flattening here. Do you see it?
Mm.
Here it's septal and compared to the RV. And then look at this one, looks very unhappy, right?
It is.
So this patient, for example, could be like a patient presenting at 6 months old with like a TGA that was never diagnosed, right? Because his RV is systemic and now the LV is completely pancake. It's not. This is a kid who had like severe pulmonary hypertension. But just to put you in line that sometimes it's because the RV is systemic and the LV is subpulmonary. Okay, so always think about assessing the pulmonary to systemic compartment balance. So either the right is abnormally high and the left is also. So for example, you could have like 120 millimeters of mercury in systole in your RV and 80 millimeters of mercury in your LV. So you're suprasystemic, your LV pressure is okay for the age. You could have 200 millimeters of mercury in your RV and 150 millimeters of mercury in your LV, and it's still going to be bowing, right? So it's like to put in relations. So one of the questions sometimes I got, oh, how come your patients have pulmonary hypertension, but their eccentricity index is normal? Well, of course you can have pulmonary hypertension with a, RV systolic pressure of like 100, but if your LV systolic pressure is 150, your LV is going to look very round and very nice. So you have to be aware of these caveats when you're looking at your echo. Look, and that's why when we did the echo, I'm like, what's the blood pressure of the patient? Because if he was hypotensive with poor output from an LV, I'll be like, oh, this is a kid I want epi. This is a kid I want dobutamine. But if the kid is hypertensive already, I don't want to put something that's going to increase a bit the SVR, and already the LV is struggling. So that's why milrinone is like an option in that patient, because I want the SVR to go down. Sometimes your right pulmonary arterial pressure is normal, and you're going to get bowing of the septum because your left ventricular pressure is very low. Think about a patient with like severe septic shock and SVR, super dilated SVR. And then because of that, the LV systolic pressure is like 10/5. Then obviously your RV is going to be like, much more pressurized than your LV. And as soon as you get a PDA that's large enough, if your PDA is like massive, by definition, you're always going to have isosystemic PA pressure and aortic pressure because you're going to equalize pressure on both sides, by definition. Same thing with a very large VSD. It will pressure equalize the two ventricles, right? Because in contraction, the two will be connected and their pressure will become the same. And it's then the directionality of the shunt that informs you more on the relationship of the PVR, SVR. Does that make sense? So we can use some markers to quantify this septal deformation. I'll go for it. We're going to stop in 10 minutes. Is that okay? Yeah, you guys are okay? You're able to sustain the extra 10 minutes? No worries. So here, bye, Phoenix. So here you have septal flattening. Okay, that's an example. And you can see this LV is actually a bit squished by this right ventricle. So don't forget that they share a common like septal wall, and they share also some muscle fibers together. So that's why sometimes the LV will start failing. Also, if the RV is not able to pump enough in the pulmonary vasculature, what's going to happen is that the LV will see less preload, and the LV also will be impacted by becoming less filled because there's less pulmonary blood flow. And on top of it, the RV being pressurized will compress through the septum. So one of the marker we do is a thing like what we call an eccentricity index, which will be the diameter of the LV parallel to the septum divided by the parameter perpendicular to the septum. And if you have values above 1.3, it's considered like, concerning for abnormal deformation of the septum. And then you have to figure out, is it because my LV has a problem and RV has a problem or both? And another marker that sometimes in research we do is that we'll divide the diameter of the RV perpendicular to the septum to the diameter of the LV. And typically your diameter of your LV which should be much bigger than your RV. If not, it's a sign that you're starting to have RV dilatation. Obviously, if you have a hypoplastic left ventricle, then these markers are not very fond. So that's just to give you an example. That's a premature baby who had pulmonary hypertension with BPD, and you can see this RV does not look happy, and you can see how you probably don't even need the eccentricity index to tell you that this kid is struggling in terms of its RV hypertension. Just because I've never showed you that, this little triangle, you probably don't, do you know what this is?
No, I just don't.
Do you know what this is?
No.
Okay, so on this image, there's always like information is always there for a reason. What does this tell you? It tells you that on your probe, you selected a range of frequency that is in the resolution space, which means that you're using the higher frequency of the probe. So I already know that this is a probe that's probably like a 6S or 9S or 7, this is probably a 6 from the Philips. And it tells me that during this echo, we used more of the range of the 6.4, 6.5 megahertz to get a bit more resolution. Sometimes you can ask the machine to go and use the lower frequencies to either get a general or a more penetration factor. So you're going to see me sometimes I tweak your images. If you're having difficulty on the 12S, I might turn it and get to like general or penetration so that the machine uses the lower frequency of the probe to try to get less resolution but go deeper.
Yeah.
So that's what this marker is telling you.
Right, the range of that of this frequency.
It doesn't, not for Philips. Yeah, but it tells you what are the kind of range of where you're at, and the machine adapts these range as you're scanning.
So you select it on the machine.
You select it on the machine.
Right now.
Yeah. Here it tells you that the grayscale color that you're using for this particular patient is an M5 grayscale color. Each machine will have their coding system, but this machine has about 6, I think, grayscale color that you can use. It really depends what your eyes likes. Then you have your mechanical index, and then you have the thermic index, which are standard by Health Canada, FDA, all these things. So you'll see that sometimes some probes get hot, like this morning. So that's you'll see your thermal index starts to go up. And then you'll have here what's your marker of your probe, like in terms of the relationship. So here it's a P because it's a Philips. If it's a V, it's because it's a Vivid from GE. If you get an S, it's because it's a Siemens. If you get a B, it's a Butterfly. So each machine will put their little logo for their marker. And then X3 on the Philips, it's because it's the X3 is a type of AI algorithm to optimize the imaging. So you have X-res from 1 to 5, basically, and it's different algorithm to try to tweak the images that Philips developed.
That's the one that you sort of put next to what you want to see.
So you'll see that when you scan. So each machine. So this, for example, is a Siemens.
So that it's
Yeah.
at the level of
So
what you wanna see.
that's the focus,
Yeah.
basically. So you can change your focus to adjust it on the structure of interest. Some machines don't have focus. Like for example, the GE Vivid E95 doesn't have a focus. It will autofocus automatically on the image. Okay, so eccentricity index has been looked at in the premature population. I've put the reference here. This is example of D1, D2, and D2 of the RV in different patients. And then we're in apical, so we're going to keep apical for the next time. Because it's 3:45. Perfect. Any questions?